One of the benefits potentially is delaying the onset of ADT in somebody who's recurring after radical therapy, isn't that right? So perhaps being able to see individual site of recurrence, for example, a lymph node. And in your practice, Chris, would you chase a lymph node with radiation, with stereotactic radiation, for example? And to avoid starting ADT in somebody who's recurring post-radical therapy?
Yes. Well, I don't need new imaging to stop me using ADT for my biochemical failure after local treatment.
Yep.
So I think there's far too much use of early ADT for men with biochemical failure after radical treatment.
Yes.
But I do take your point that the new imaging techniques do identify more patients with apparently oligometastatic disease that we didn't pick up in the past. And certainly my bias is to treat radically where appropriate with radiotherapy or even with surgery to oligometastatic disease. I fully accept Bertrand's reservations. I haven't got randomized trial evidence to support that, but that is my bias.
One of my most famous paper I will ever have written is a paper called Chasing Pokemons, which is called the Pokemets, which actually what's happening in Europe, which is an editorial we wrote with Chris Sweeney and Declan Murphy. And in Europe, for instance, where we have PET PSMA for several years, we have whole body MRI, the European HTA, so Health Technology Assessment, something our colleague in the US don't know yet, but you will soon discover, came to us and say, you know, there is a rapid increase in the use of stereotaxic radiation therapy that is driving a major increase in cost. And Astro and EORTC are now setting up a platform about this, because this is not limited to prostate cancer. It's lung, breast, GI, prostate. And because we want to understand what is driving the decision to treat, and at least in a first step, try to isolate patients who clearly don't benefit. Because you still see a lot of these patients, you do a PET PSMA, you do stereotaxic radiation therapy, and then 6 months down the line, they've got metastases everywhere. So once again, we're getting better, but we still have a long, long way to go.
I guess the counter argument would be if you treat 10 patients like that and you cure one of them, it's worth doing.
Yeah, that's the typical decision, but we need to understand at least the two that clearly don't benefit.
There's a lot of patient pressure to actually do this.
Yeah, of course.
And we experienced that, in fact I've experienced that this last week, you know, and it's quite difficult when the patient wants it to say no actually.
But
there's no data.
But that's when I would agree with Chris that I've been spending my life trying to better understand ADT, but that's where clearly one shot of stereotaxic radiation therapy by far is less toxic than 3 years of ADT.
Agreed.
Exactly.
That there is absolutely no discussion, and you don't need randomized trial to understand that.
And if it was me, and if I had oligometastatic disease, you know, I could have hormones alone and be certain of not being cured, or I could have radical radiotherapy with a chance. Even if it's a small chance of being cured, it's still better than no chance.
Yeah, that's certainly my practice as well, very much so.
But I'm still surprised how much men, they do accept ADT like this.
Yeah.
It's probably because they probably don't realize what we do to them. And they don't.
It's too late.
Usually they challenge you after 6 months when it's too late.